this sequence of nucleotides containing CpG motifs, we can simulate the toll-like receptor 9. On this slide, you can see the numerous clinical studies that were started straight away to try and use these synthetic polyconglutides and the LTR9 and see if it was possible to obtain an antitumor effect by simply stimulating the immune response. In man, studies were not precisely disappointing, but not as enthusiastic as we might have thought. There were some partial responses, some complete responses. However, they were not particularly exciting, not even in phase 3. In man, these oligonucleotides were taken and inoculated, especially in patients with advanced neoplastic diseases, to see if survival could be improved.
Questo è stato un errore perché si è pensato essenzialmente di stimolare l'immunità adattativa, mentre agonisti dei toll, dei toll sono, ci si è accorti dopo, sono essenzialmente degli stimolatori dandolo sottocute, si pensava di stimolare l'immunità adattativa, stimolare l'immunità adattativa comunque in generale gli linfociti non si è stimolata in modo adeguato l'attività innata. Ci si è accorti dopo queste cellule che riconoscono questi oligonucleotidi sintetici non sono solo le cellule, ma abbiamo tantissime cellule, sia bone derived, tipo monociti, macrofagi, monociti, sia non bone marrow derived,
epithelial cells, endothelial cells, fibroblasts, etc., that are able to become activated by this toll-like receptor 9. And the activation gives rise to immediate protection, but local protection of the immune system. This slide shows an experimental model indicating the difference between local stimulation and systemic or subcutaneous stimulation using these toll-like receptor agonists. As you can see, this is a model for ascites, for ovarian cancer, correction. The carcinoma was inoculated in the mouse peritoneum, and you can see that an inoculum, a small dose of the oligonucleotides inoculated subcutaneously or IV produce protection, but only really very relatively, whereas if the oligonucleotide is inoculated into the area where the tumor cells are present, the protection is much stronger. Therefore, the negative data obtained from these clinical trials, or that weren't so positive, probably were due to the route of administration. It was subcutaneous. It was not into the area where the tumor cells were present. And so the natural immunity only functions locally, in other words, where the infectious process occurs. The adaptive immunity occurs and develops much further away as well. And the other issue that caused these substances, these infectious substances that are implied in inflammation to function poorly in these patients enrolled in the trials, was because the patients who were selected had advanced stage disease. The tumor mass was very large. An activation of the innate immune system on a very heavy tumor mass was unlikely to control tumor growth. But more than that, the cells activated by the oligonucleotides containing hemo-TBCs were natural immunity cells like granulocytes, etc., which have a very short life. They're activated very quickly. They produce their active substances very quickly, but then only hours or days later, they die. With the inoculum taking place once a week or once a fortnight, as in most of the trials, this caused the activation to be very low of these natural immunity activation. And here you can see the healthy controls in the first line. Then you have those that had the administrations every 7 days, and then five times a week in red. And as you can see, the treatment, these were mice. The previous ones had ascites. The disease was already very significant. And as you can see, even one administration every day, constantly stimulating the natural immunity cells, this enabled survival to increase. Therefore, in order to obtain this increased survival, it is necessary for treatment to be local, where the tumor mass is present, and the treatment activating the natural immunity, the innate immunity, has to be repeated constantly. And however, it was very unlikely that